Hi, Susan. This is Lynn Shell, and I'm on, but I can't see anybody or hear anybody, so I'm not quite sure if this is going to work or not.
There seems to be only four people.
It does seem to be only four people. But I can't see anybody, and I kind of feel alone here. So if you guys want to just join me, at least with the video, it would be nice. But I get if you don't want to.
I don't mind, but I'm driving at the moment, so I can't really. I'm not looking at you. I'm just listening.
Thank you, Jazz, for that feedback. And at least I see Susan and Melissa. Oh, I see. Oh, I'm so not alone. Thank you so much. I know that there wasn't a lot of lead time to this, and I'm not quite sure what happened there, but I'm really happy to see you all. I usually give it till about 5 after before starting. So far, I know that Jazz, who I saw in a tiny glimpse, and she is in fact in a car. And so that will make 1, 2, 3, 4 of us. Have you all had a chance to read the article?
Yeah. I haven't, but I have an interest. I work with a liver surveillance in the UK, and part of that is going into organizations that work with people that have misuse issues or addiction issues. And so that's why this is really interested to spark my interest. So that's why I've joined.
Okay, well, I have to just, excuse me while I just, I'm going to shut off my video for 15 seconds while I reach across you so that you don't have to see and know what I'm, me up close. You're close enough as it is. 15 seconds, I was pretty much on the money. I have no idea what the weather could possibly be in the UK, but I do know it's hot here in NJ, here in New Jersey.
Yeah, it's hot here too, but not too badly. Last year this time we were having like record 40 degrees and stuff like that, but this is more manageable. It's about like 20 to 25.
Okay. Wow. I don't know where are the others. Susan, where are you?
I just got my certification in CON, so I'm a certified addiction registered nurse. I'm also an LCSW with my R letter. I work in Wellbridge, which is an addiction and treatment center and research center for addiction and detox in Calverton, New York. And I also have a practice as a social worker. And I work with people over the world because I work for an organization that lets me see people over the world as a social worker. So
I'm sorry, did you say that you work for an organization that allows you to see people all over the world?
Yeah.
Oh, wow. What organization is that?
I really don't want to disclose it.
Oh, I'm sorry. Okay.
That's all right. It's just like I like to be private. It's a lot of these online therapy places during COVID were able to do it, and they're still able to. Although some places I just do it, and I can't call myself a social worker, so I'm a coach, so to speak. But I am a licensed. I am in New York State. I'm considered a licensed therapist, psychotherapist.
Okay.
But I specialize, I guess, in addiction. Didn't always, but I've been doing addiction for the past 10 years as a nurse, and I guess 40 years or something as a social worker.
Susan, it makes me think that, I wonder if there's a way for people to network and know what other people's abilities are, because I certainly work with students who travel in the summer and would benefit from having somebody that they could talk to. It's interesting. Yeah.
Yeah, I'll give you my information, sure.
Well, I'm just saying, I think in a bigger sense, there are probably many of us who have interesting and somewhat different ways of working and could be of interest to each other. Anyway, thank you and welcome for joining, and congratulations on the CARN certification.
And what are your credentials?
Sure, I'm happy to share. I haven't done this before, but I was just thinking that it's a great idea. So my name is Lynn Shell. I'm a mental health nurse practitioner. I work I work with students, 60 students, or Christian theological seminary students, and that in my private practice. And then I have a once a week or once a week gig at a substance use facility, which I've had for 23 years. I just keep going back, keep going back, keep going back. So
New
I work
Jersey.
in New Jersey. Oh yeah, sorry, everything is in New Jersey at this point. And I have my PhD. I used to teach at Rutgers, but now I'm of the age where I just kind of don't do that anymore. Trying to cut back gradually. It's nice to meet everybody. Thank you, Barbara, for joining me visually, because it's really hard I have a hard time talking to myself, even though I know that there are plenty of people who are audio only, and I also understand that. So today, usually we have one of the authors with us. We don't today. So I'm sorry about that, because I think they always add an extra dimension to just a kind of a dialogue that we all can have about this article. So we're talking about the nurse's attitude towards patients with substance use disorders. And remember, all of you, that you can get CEU credits by, hi Alan, you can get CEU credits if you go online and do the test, and I think you get 1 credit hour for it. So it's worth it. If you're a member, you go on to the membership section of the Insta website, and it will take you to a place that I think that gets you a reduced rate on the CEU exam as well. So hopefully you'll get a chance to do it. So as Susan and I were just saying, I work in an outpatient facility with substance abuse, for substance use and abuse, no longer just abuse, right? So I work outpatient people, and I specifically work mostly with the people who have co-occurring illnesses. And I'm always intrigued when I read about situations where larger groups, in an inpatient setting, for example, inpatient or even a PHP setting, where you have a bigger work pool. I'm the only person who is the nurse practitioner at my setting. We have 6 therapists who work with the clients, but I'm sort of alone in my role. But I would love, so I always want to hear what the rest of you all have to say. Yeah, Susan. Could we add in the chat who we are and what we work and what our credentials are? And I think that's just a great idea. So if people want to just go ahead and do that. So this article is about nursing attitudes. I think we've read numerous articles about nursing attitudes and what influence that has on the clients that we work with. I think this was the first time, though, I really thought about, and in those situations, they're really talking about education, right? And how does education impact what we do with our clients? This just felt a little different to me, and it was kind of intriguing. It really talked about how the education we give changes the attitudes and how those attitudes impact the clients that we work with. So it made reference to the theory of causal attribution belief, which maybe you all were familiar with, but I was not. I needed to go back and do a little research on that. Essentially, it talks about making inferences about the causes of what struggles we might have, and whether those causals are behaviorally based or not, or if they come from somebody else's experience. That was pretty interesting for me. I don't know, again, I don't know if it was new for anybody here, and if somebody has more information on the causal attribution belief, I would really be interested in hearing about it. I think, remembering that I used to work at Rutgers, when I think of causal attribution, I think about how some students, some people are, for whatever reason, believe that hard work is going to create a good grade. And so they are encouraged internally, because of that belief, to continue to work hard in their attempt to get good grades, as opposed to somebody else who maybe thinks that no matter how hard I work, it's not going to make a difference. And so they might be less interested in working to improve their grade. I think that's really much an oversimplification. Anybody want to add to that? Yeah. Anybody? Okay. Anyway, that was one of the things that I thought was sort of interesting. And then, of course, the fact that negative attitudes from the nursing staff is going to influence somebody's progress in their treatment.
I read a interesting paper. I don't have the reference now, but it was talking about self-awareness as a tool for nursing, and gaining self-awareness, and it then enables you to be a better nurse, have a better attitude, and support somebody else's autonomy.
I like it. I like it. I think. Go ahead, Jess.
Yeah, sorry. No, carry on. I was just it's like multitasking. Sorry.
Just don't get into an accident.
I know. Yeah.
I don't know.
Once I stop, I'll be able to get the reference and everything.
Somebody else looks like they're in their car. Welcome. I have clients who think that we can have a session online while they're talking, and I have to say, that's not going to work for me. I think that's a little. But yeah, I think self-awareness, and we know this from the clients that we serve, right? The more self-awareness you have, the more meaningful you can make your life, and the more meaningful the changes can be, which is, I think, what you're saying, right, Jazz?
Yes, but also as to having self-awareness of your own limitations, your own sort of prejudices, or ways of doing things, and then mitigating that. So once you've got awareness, then you're able to mitigate that to enable somebody else.
Yeah, I think there's an important part to that, right? So first you need to have the self-awareness. Then you have to have the drive. You have to have the motivation, whatever that motivation might be, whether it is hopefully the helping your clients achieve their best self, helping them achieve sobriety, or whether it's making sure you can continue on your job because somebody might be evaluating you and might be suggesting that maybe this isn't the right position for you. So yeah, I think self-awareness is part of it, a motivation to continue to work towards it. And I guess that's part of the understanding also that might come into this 6-hour program, that the 8-hour program that is the basis of this study, right? So learning about just some of the didactic pieces about substance abuse, and some of the other things that you're sort of discussing, what we're starting to discuss anyway, about personal motivations, what it is to be dependent upon substances, etc. And then questioning how you feel about it. There was, did you guys happen to look? I was unfamiliar with it. I don't know if anybody has used it, the Drugs and Drug Users Problems Perceptions Questionnaire that was given to the nurses before the program started. Hi, Barbara. Before the program And then I think it was 20 days or 30 days after the program ended. Anybody get a chance to look at this? No.
I did not know.
Has anybody used it? Which is more intriguing to me. So this was a question that was put out to the participants, to the nurses, and it asks them 22 questions. The article describes it. Let me just see. It talks about role adequacy, role legitimacy, role support, motivation, and task-specific self-esteem. And then the last one was work satisfaction. So this was sort of the tool that they used to decide if their 8-hour program had an impact or not. I had to download it separately. It was not part of the article, but it was free online.
So where was the study done, and what was the cohort?
Okay, let me turn to it. Let's see. Okay. Nurses in psychiatry departments at an urban hospital who signed up for an 8-hour workshop pertaining to nursing practices for patients with SUDs. It doesn't really tell me where it was done, other than, as I said, just to say an urban hospital, but the authors are based in Maryland. So my assumption is it occurred in the Baltimore or Washington, D.C. area. They had a total of 78, let me see, 78 participants received email surveys, 46 completed the pre-test, 45 completed the post-test, and 24 people completed the 30-day follow-up. Which the article also states, when you look at the statistics for other online testing and online evaluation tools, was a pretty good response rate, which surprised me. 53, it looks as if there were 53% of the participants completed all 3 surveys. I haven't done survey research myself in the past. Has anybody done survey research? Not so many. So that's, anyway, 53% sounded pretty good. And it seemed like they found that there was some improvement in people's attitudes, participants' attitudes, from baseline to the post-test. There was a significant change in role adequacy, but no significant change in motivation and self-esteem around the nurses, which, now that I realize I said that word motivation before, Jazz, brings me back to what your comment was, that sometimes just learning about yourself and self-awareness is important, but you still have to have that motivation to implement it. You still have to believe it's an important thing to change.
Yeah.
Which was really my question throughout as I read this. And I really do want to have a conversation to hear what you all thought. I feel like I've just read so many articles about programs and educational programs that we are giving to nurses and to clients. But I don't have a sense for what kind of actual change it made in terms of interactions between the nurses and the clients, between outcomes. Was there a change in outcomes? That was the part that I felt like I was missing.
it feels like the cohort was too small. Maybe it's like a pilot study, and then if it was, then there needs to be a bigger sort of piece of research with more participants.
Absolutely, yes. I mean,
Yeah.
I think that's kind of the thing we always say, right? It's not really enough people that we have studying, and I think in this particular case, that's true.
Mhm.
I'm trying to see, larger sample size would increase our statistical power, although our current sample produced some significant outcomes. So yes, but I'm not even sure that they were looking to see the outcomes in terms of actual, well, I guess the only question I would have is, I get that the nurses perhaps have changed their attitude, have changed their approach, but did their clients sense that? In any way, did it make a difference to the clients that they serve?
Mm.
To me, that's sort of the point,
Yeah.
right? And I don't know, but that might take a little bit longer. So do any of you work in an IOP setting, or where you work with groups of clients? I don't even work with groups.
I work
No.
inpatient, but I work with groups of clients. I do at least 1 to 2 groups a week. And one of the groups I'm working with has to do with stigma, and I try to help them compare their disease, accepting that they have a disease and comparing it to diabetes. How that when you have, it's normal to have setbacks with chronic illnesses, which is also normal in addiction, um, and and just helping them reduce the stigma for themselves, even though they come across it with professionals as well as family members and colleagues and friends. So that's been a big thing I've been doing readings about and research and trying to help my clients with in the groups.
So Susan, you told me that you were a social worker. That was your first career.
But I work as an RN, and they're very strict about me staying as an RN in my lane, in my place. All the places I worked with before actually gave me money for my licenses, and I have 3 years postgraduate training in social work with someone really famous, but they don't recognize it. They say, no, you're a nurse here. If you want to be recognized for being a clinician like that, you have to go to the other department, which I'm not going to do because I'm not happy with a lot of the things in clinical. But I mean, I like my organization, and I love the patients I work with, and I love the work. And I think one of the things I was reading about in the article has to do with role adequacy and legitimize your legitimate role as an RN. And I think that, and I thought it was interesting how new nurses that they distinguish between new nurses that have been for 2.5, 4 years, and then nurses with much more experience in terms of how your attitudes have changed, and they've kind of maybe
First on lower jaw. Hola, mandíbula. All right.
I can't
I'm
hear.
sorry, I can't hear you. I'm sorry, Susan. I didn't hear what you were finishing up.
I think it's interesting how they compare role adequacy and legitimacy of roles with nurses and their attitudes in terms of their years of experience with new nurses, 2.5, 4 years, and then nurses have been there a lot longer. And, and I think it's interesting because some nurses in other fields, even in psych hospitals, they have, without realizing, negative attitudes about people with substance abuse disorders, maybe similar to people, with diabetes. Well, why haven't you gotten it together? Like what's going on? So I just think that's kind of interesting. Even like with professionals, they have a hard experience, especially people with pain. A lot of people that are in addiction have really serious issues with pain problems, and they don't recognize that people with opioids have a lower tolerance for brain, and they don't want to, the way they prescribe medicine isn't even beneficial because of that, and then they don't want to prescribe it because they're afraid they're being conned. And patients often feel this way. They feel, they'll share it. I don't even want to ask for it. They think I'm med seeking,
Yeah.
So that's why I think it's interesting. The article is very interesting to me. To talk about this.
I think the legitimacy is such an important part here. What you were starting to talk, and I think somewhere in here they talked about obesity and the judgments that we bring to clients who are, however you want to define it, whether it's truly fits the obese range or if it's overweight. And I can remember working with one particular cardiologist. This was before I became a psych nurse. And he was so caustic. He would berate people verbally for not following his rules and eating. And he had just such offensive language that he used. It was blatant, and I think there's that blatant language that we use, but there's also that undercurrent of the subtle messages, the way we look at people, how we talk to people, that I don't know. And that goes back to self-awareness, Jazz. I don't even know that we realize what we're doing sometimes. Excuse me, my battery's about to go down. Hold on. Much better. So I don't think this is limited, and I think that's what you're saying, Susan, as well. These are concepts that aren't limited to the substance field. They are pervasive concerns that we need self-awareness for, to know how we're talking and touching people in our interaction.
Lynn,
Yes.
I have to swap over and get out of the car. I'm going to try and put you into earphones, but if I have to dial back in, will you let me in?
Of course I would, Jazz. Of course I would.
Thank you very much. I'm hoping that I won't have to do that, but
okay.
I'm just putting the earphones now. I'm turning off the engine.
Thank you. So tell me, I thought this was interesting also. It said that only 3 states require nurses to have continuing education on substance use disorder. I know here in New Jersey, you have to have, I think it's either 6 or 8 hours. I think this is all related to prescribing opioids. But those of you who are in other states, do you know what the restrictions are, what the law is in your own states? Because this implies that only Delaware, Florida, and West Virginia require CEUs for licensure.
Are you talking about RN or APRNs?
Well, it just says in only 3 states required nurses.
Right.
So I'm assuming it's RNs. I don't think it's
New York doesn't require it. Florida has more restrictions. I worked in Florida for 3 years.
I mean, that certainly isn't enough. I think we do need to have more education. I think that's one thing that this article and every article that we seem to read seems to point to, that we need more education for nurses. So what did anybody get from this article? Is anything going to change in your practice from this article?
I would say it's, I don't know that I'll necessarily change, but I would say definitely it serves as further underpinning that I need to continue to educate even among my nurse colleagues, because I'm in a practice where we have integrated care, and that is medical and mental health together. And I'm the only psych NP. And so I have 6 other medical colleagues who, of the 6 of them, probably 4 or 5 think they're practicing outside of their scope. They don't want to do MAT. Why should I have to work with them? So I think that it just serves notice of how important it is for us to continue to educate. and advocate for care, because it is really not any different than a diagnosis of having diabetes. So changing the conversation around it, changing how community members are approached and how they are managed in their disease process, that it just tells me I still have work.
You still have work, Twana, you
Yeah.
still have work.
Yes.
You're the only mental health person. Are you the person who sees all of the addiction patients?
So I don't see them all. I see a lot of them, and the more what they would call unstable cases, they're all mine. So like they would call unstable immediately. Oh, she's pregnant, she's yours. And so, which is okay with me because I worked inpatient substance and psych, and a lot of our population came from around. North Carolina has 100 counties, but many of them, if there's a diagnosis of opioid use disorder and pregnant, they immediately ship to us. They want nothing to do with them, right? So I took care of a lot of them. So I don't see them all, but 1, 2, 3 of them are waivered. 3 of those medical NPs are waivered, and they do have a very small caseload of what they would call extremely stable MAT patients. And so it's mostly me, which I don't mind. I'm all right. And I'm even happier since they took away the requirement about the numbers, because, some of us were topping out the first year and saying, hey, you need more. You don't have enough. You need more numbers. So I'm glad that's gone, and I don't mind. But the thing is, I feel like they need to just be educated that many of these folks that we meet, they're going to be identified in primary care before I ever even know anything about them. So you got to get comfortable, because this is where it's going to be discovered.
I love you, Dwana. So
Yeah, I love it.
I have worked at the same outpatient facility. I'm embarrassed to say this, 23 years, same place, 1 day a week. And I've run the gamut. I have worked their prevention programs. I've worked the clinical programs. I've been the mental health nurse practitioner there for, I don't know, maybe like 18 years, but whatever. I am golden there. And I am golden because the person who, they had one psychiatrist before I got there. She would not shake anybody's hand. She wouldn't touch them. She barely looked at them. She had a very negative way of talking and speaking in a very condescending way to the clients. She wasn't much better to the staff, apparently. So no matter what I do, anybody who remembers her, I am golden. But because I work in a substance use facility, I would say my situation is different from yours because everybody cares about this population. Everybody I work with cares about the population. The people who don't care about the population are the people up above. The municipality, the overriding government forces don't understand mental health, don't understand substance use, and really don't think we need it in our community, which is ridiculous. So I know what you're saying. I know that there are some people who think anybody who has a problem should see mental health, should come to see me. I'm supposed to only see people who are dually diagnosed, but I'm telling you, when anybody acts up, they think they need to see me. Or there are people who are on the flip side who think mental health isn't, people are just not, what's the word I want to use? If they don't see it as mental illness, they might see somebody as just not nice, not working hard, not trying to do anything. It's like the two extremes. It's the two extremes.
I would say you're absolutely correct, but I would say too, a lot of times when I see that and that sort of black and white thinking like that, when that's not real life, a lot of times they just very uninformed. And, I'm a very huge advocate for therapy. And so sometimes when I'm with my community member folks, patients, clients, whatever y'all say, I say, we've identified this thing that, it's maladaptive thinking. And are you this committed to being, ignorant? I usually don't say the word ignorant, but like, that's really, are you going to be that committed to something that is maladaptive thinking? Are you more committed to making these changes that, let's go back to your goals and say, what did you ask to accomplish? How did we amend that as we went along the way? I'm so big on that. So sometimes when you encounter people and they're that way, it is because they are committed to not learning, not changing, not growing. And we know that that's not consistent with real life because things change, they grow, they jog left, they jog right. It's no straight path, right? So yeah, that's just education.
That's part of the reason why I like this reference to the causal attribution belief, because it doesn't just say we need to think about the academic piece to this, but it means we also need to think about the message that we say, that we need to make sure we're saying, you can do this, right? This is something you can do. This is not there's no end point. There's no end game here, right? People relapse, but it doesn't mean that we can't keep on moving forward. So I thought.
I tell them, sometimes we have setbacks, right? And it doesn't matter what it is, whatever our diagnosis is. Number one, we are not the diagnosis. Number two, I say, this is your own journey, unique to you. You are for those of us who are old enough to remember, you're Crocodile Dundee with your own machete, and you have to hack out your own path. And sometimes that means it's going to jog left, it's going to jog right, it'll go forward, it'll go back, but it's all a part of your process. And already become an advocate of not beating yourself up. Give yourself grace. There's no path. Just like when you have kids, excuse me, they don't pop out with a manual, wish they did. You have to figure it out. And it's not going to be perfect, but that's where giving yourself grace comes in, because that's what you have to do if you intend to make it and go forward.
The other reference. Oh, hi, Iris. Wow, wait, Iris, I'm
Hi.
Hi, welcome. Wow, I'm so happy you're here.
Yes, yes, ma'am. I'm also very happy, but for some reason my video is not starting here. There's a problem with the video.
Well, there's a problem with video for a lot of people here, right around the corner. So it's okay. I didn't mean to single you out, except it's just exciting to have somebody who I am.
Yes, me too. I've been watching this for some time, but then I could just see that all are very experienced people in the field of addiction nursing, and I'm just a novice here, trying to understand about this. So I was also apprehensive, but then it's good to hear about the experiences.
Oh, well, it is good to hear about your experience, everybody's experience, and you are, as a new addictions nurse, are you new to nursing in general or just new to addictions?
New to addiction, ma'am, since last 3 years or so.
Okay. Well, welcome.
Yes, thank you.
I'm just going to talk again because I think the point of the article was really about the attitudes and how we approach people and the impact about it. And hopefully that the more education we give, the better and the more accepting our approach will be, so that people won't feel like the staff are stigmatizing. I think there's enough other people out there who are really forcing a stigma upon people. I think I was reading another article related to this about people who inject drugs and the stigma that goes along just by virtue of being somebody who injects medication. But what I was just going to say, besides the fact that I do wish they had continued the study for longer than 30 days, I would like to know how long this effect of making people more aware based upon this 8-hour program. But oh darn, now I can't remember what I was going to say. But it does suggest that if we work on education with new nurses, but not just new nurses, I think that the message was clear that we need to really look at people and how long they've been working and correlate that with what their particular needs are, at least according to this study, in suggesting that people who are new to the business, new to addictions, might need a particular type of education to be the basis for what they're working on for those 8 hours. And somebody who's been in the field for a longer period of time might benefit from something else. So I thought that was really also helpful in terms of if you're going to design a program to give. One of the things that I would have liked to have known about the subjects, and again, I'm curious about what your experience have been. There are many people, I think, who work in drug addictions who have their own personal story, be it they're a family member, a friend, they themselves. And I don't think that they accounted for that in the people who participated in, and their own sense of stigma, both as a person themselves and how they treat others who have addictions. Anybody have a thought on that?
I find it interesting that I'm not in recovery. I don't have a problem with addiction. But I find it interesting that out of all the patients I've worked with that are professionals in all different fields, nursing is, I think, one of the hardest and worst punishable, at least in this country, when nurses are found to use something. I work with a lot of physicians where, I'm talking about anesthesiologists that right after their surgery they were using, and they walk away without any kind of repercussions other than joining a program. And everything's paid for, and it becomes much more difficult for nurses. I find that interesting.
So I think what I'm hearing you say is, here's what my experience has been. I've worked with nurses who've been found to be using patient substances. And in that program, it's a pretty extensive recovery program, the back to work program, the supervision. It's a multi-year process. Whereas doctors frequently, even if we know about it, it's not an uncommon thing to look the other way or to just say that they need to get.
No, that's not what I'm saying. My experience is that if they get caught, they hire an attorney. But I'm saying that they will go to a program. I have a lot of them in my place, and they share with me how they're able to go back to their job, no restrictions at all, and even in terms of legal costs, everything is compensated. Whereas nurses, they get fired.
Yeah.
There's just a lot more consequences legally for them than they were for the physicians.
It's a multi-year process. Yeah.
It was called the Old Boys Club. I don't know.
My experience has been in the 70s. I happened to work on a drug detox. No, it was a medical, surgical, psychiatric, chemical dependency, heroin, you name it, medical surgical unit. And two of my colleagues happened to both be alcoholics. And it was totally oblivious to me. I was young at that time, in my 20s. And it was the patients who pointed it out to me. Then about 10 years later in the 80s, working on a 28-day inpatient rehab program. It was modeled after Betty Ford. We had a physician come in who ultimately, and when he came in, he was in DTs. He signed himself out of the hospital and contacted us to ask us what the detox schedule was and the phenobarb so he could self-medicate and take himself down. Then he ended up coming back, and ultimately he became a physician. And I agree with what you're saying, Susan, who actually worked exclusively with recovering people, which I commended him for. But I find that doctors have their, I think it's called the Caduceus Society, which is their form of AA or what is it, Narconon, that type of thing. And I agree. And I also worked on that 28-day inpatient unit with a nurse who was a recovering heroin addict. And her track marks and everything were very visible. And she was somewhat, as in the nursing role as a staff nurse, was very good with the patients because she could easily relate with what they were going through. But she was the first nurse that I met who had a heroin habit, who was given her license back and able to practice on a drug unit where we were dispensing methadone. That was the surprise to me. But I agree that for the most part, nurses have a harder time. I attempted to, well, I was involved back in that day with the nurses association that helped RNs who had an alcohol and drug problem. And today it's called SPAN. So I've been looking into the possibility of volunteering and doing some time to work with them. I just haven't gotten around to it. But through the union 1199, they make those things available to nurses.
Well, I had not heard about the Caduceus Society before, though I feel almost like I might have heard some sort of reference to a society. So thanks for that. I'll have to look that up. Not that
Yeah, I'm not sure of the name, but I do know it's almost like it's a secret organization where the medical doctors, physicians are able to go and have their separate AA and separate whatever they need in terms of their recovery, their 12-step, they're doing 12-step program. And I don't remember when I worked in the methadone outpatient clinic, I don't recall any doctors, but I know we had a lot of lawyers and judges and people of that status, politicians as well, who we medicated very early in the morning. They would come in at 6 o'clock. We opened at 6 a.m. for them to be able to come in, be medicated, and they were also, of course, over time allowed to take home a monthly supply of the methadone. They didn't have to be in the clinic and being observed.
Well, I'm thankful that such a society exists. I mean, I certainly would want there to be a place for everybody to go. And so if that's a place that feels safe for physicians, I think that's fine. I have worked in a place where there was a nurse who, as you described with the track marks, the clients really, I wonder if this is, this is Jazz who's talking, right? Myra? I think. Anyway, when we worked together, the clients who were part of that program really connected with her.
Yes.
They felt as if she was speaking their language, but more than that, they felt that they were somehow respected by her more than some of the other treatment providers. And I don't know that her interactions was different or not, but it was certainly perceived to be different by the other people. And that's a wonderful opportunity, was a wonderful opportunity for her to feel like she was making an impact and in some way giving back.
Well, the nurse I worked with on the 28-day inpatient unit who had the track marks, I admired her for her courage. And the patients definitely did rally around her because she had lived the experience. She had had the success of an achievement, what society looks upon as being accomplished. And then she had this habit. So I think it instilled in our patients that there was that hope, that possibility for them going forward.
Mm-hmm.
I find the field working with chemically dependent people extremely rewarding. And I really love to see when there is a full recovery. For me, full recovery is they do not return to drugs. They work their program and they become gainfully employed, because that's the ultimate goal, is to restore them so they can be gainfully employed.
That is the goal.
Yeah.
And for me, it was so rewarding to see this one client of mine who I met her when she had just had her, I don't know, third or fourth relapse. And she worked the program from that point on. And together we worked her through the nursing program and all of the things she had to do for the nursing program. And she just told me she's applying to be a nurse practitioner now. And she does work in the addictions field. So I think that there is certainly a place. And especially now when you think about how important it is in terms of stigma, right? That clients can understand that where they've been, what their potential is. And just that, I think that has to make a difference for the clients that we all work with. Is there anything else that somebody wanted to talk about with this article? I want to make sure everybody had a chance to say anything they wanted. Pretty quiet. Well, I think, gosh, makes me want to go back and really talk to people about stigma and the importance of stigma, and bring people, I don't know how to developing self-awareness in a group setting can be really hard. So if anybody has any ideas, I would certainly benefit from it, because I'm going back to what Susan said earlier, that we sort of need to know how we are when we're with our clients.
I don't know. I think, information is power. And it's similar. There's a book called it's Caroline Pert. She wrote about cell and about the cell, the human cell, and that was the first consciousness. And what she was saying is that she would go into, because what she was doing, she was a scientist that was studying like the addiction. What are the ligands that are attached to a cell that make somebody addicted? And she did a lot of work on that. But it was like in explaining. So she went in with a group of inmates in prison, women. And she sort of explained and gave them sort of like a picture of what was happening with their bodies, and how the cells and what the actual the attachments were, and how that was such a pull, like a physical pull of the body's need, that forced them then to continue to want to use. And
so it's called,
and in explaining that, then they had an understanding of what was going on inside of their bodies that was creating that need for that particular drug.
And who was the author? Do you remember?
Caroline Pert. I can't. I'm just trying to look at my bookstore to see which one it is.
Because I just wanted to remind you all that the article references the Drug and Drug Users Problem Perceptions Questionnaire, because after reading this article, and I know we do a lot of education with the clients, but maybe it's time for us to go back to our own staff and revisit some aspect of the addiction nature. And your book might be the one that will really, okay, you're ready.
Can I
Tell
show
me.
you this? I don't know if it comes through. Does it come through?
No, it's a little foggy.
Let me try
Molecular-
changing the way the picture is. Hang on.
Was
None.
it molecular?
That's it. This one here.
Oh yeah, molecules of emotion.
Yeah.
And PERT. Okay. Oh, Candace.
Yeah.
Okay.
And so did you get it?
I did.
Okay.
And so again, I think it looks like
sorry.
It looks. That's okay. No, I just want to say again, I think it's not just, we need to, think about whether this is effective or not. So I just invite you all to download for free the DDPPQ, which is referenced in the article, which is the Drugs and Drug Users Problems Questionnaires, Perceptions Questionnaire. And just see if we're making any impact. And if not, maybe we need to just revisit it and change the approach that we're having. But my takeaway is the importance of doing this education with staff, no matter how old or young they are, no matter how long they've been working or not. It's easy to become jaded. Is that the right word? It's easy to get stuck in a way we've always done things and forget that we're really talking person to person with a lot of clients. So, and again, can you see this? I see you looking at it, Susan. It's referenced in the article. I think on the very first page is where I got it. It's on page 214. And as I said, you can get it. You don't have to pay anything. Anyway, thanks so much for you coming and participating. And Jazz, you came in your car and you got out of your car, and somebody came all the way from India. And please come back next time, because if I start on time, and if I'm doing well and you all are doing well, I don't even know what the topic will be, but the conversation I think will be good. So thank you all.
Thank you.
Thank you.
Bye.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.